Oh, now I can. Can you hear me?
Yep. So just let the participants are in already. There's already 28 there.
Okay.
So Betty, can you let people know what happened? And because we can start now. Kia ora, everybody. Really sorry about that. We had to go out and come back in again, but welcome to everybody who have joined us tonight. We had a couple of technical issues. We were here about nearly half an hour ago, and then we had to come back in, but welcome everybody. And thank you so much for joining us. We're just gonna leave it to Robiti to start off with a word of prayer, and then we will start this webinar. Okay, Robert is saying that he can't hear. So what I will do is that I will, there must be something wrong with his computer. However, thank you for Dr. Ai Ling Tan, who is a gynae oncologist here in Auckland for, talking about this really an important topic on endometrial cancer or cancer of the womb in women of reproductive age. Kia ora and kia ora ni sambula. To Amanda, Fiji, and welcome to you all. Lovely for you to join us tonight. So I'm just going to start off with a word of prayer, and then we will I'll hand over to Ai Ling, and then she will start our session. Father in heaven, we just really want to thank you, Lord God, for your mercy and your grace and your love. Thank you that you're always with us, and thank you for our people in the Pacific. Although I know that there are some of our Pacific countries, especially Fiji, who are struggling with the COVID, Lord God, and now currently there is a community outbreak here in New Zealand, and now we're in level 4 from tonight. Oh Lord our God, we thank you for your mercies that are new every morning. Thank you for your covering protection upon us. Thank you also for Dr. Ai Ling Tan, who will giving us an update on endometrial cancer, and also a warning for our Pacific health clinicians of what may be coming in the future. So Lord God, we commit all these things in your precious name we pray. Amen. Thank you. Thank you, Dr. Ai Ling Tan. Now I will hand over to you. I'm going to mute. And for the beginning of our session, welcome everybody. Kia ora, kia orana, whakalapalahi atu, ni sambula vinaka, iorana, and warm greetings to you all. Thank you.
Thank you, Karen. Thanks, Ropetti. I seem to be a regular feature on this, so I hope people don't get too sick on this. And Karen had this brilliant idea that we're going to talk about endometrial cancer and obesity. And I'd just like to share my screen to start off with. And unfortunately, it says here, host disabled participant screen sharing. Sorry.
So Ai Ling, I'm going to ring him, and you can, if you want to, in the meantime, keep talking, and I'll let Roberti ask him to allow you to screen share.
I must be refreshed. Can't screen share. Kara does this to me all the time. So the actual conversation is about endometrial cancer and obesity, and I guess from my perspective, it's really about New Zealand. But I think that it's a good warning, and it's just some very simple messages that I like to share. And it would be great if we could start that with us. With the presentation, but unfortunately, I'll just have to wait until I am allowed to screen share. So bear with me, folks.
Yeah, so Roberta is going to allow screen sharing very soon with you, Ai Ling.
That was lucky. You mean I'm not riff-raff anymore? Right, so here we go. My topic today is obesity and endometrial cancer. And obviously, I'm a gynecological oncologist, so I'm very basic. I'm a surgeon. And so we'll hopefully be able to give you some takeaway messages from this. The cancer that I really want to actually focus on today is that of a type 1 cancer. I mean, endometrial cancer, there are 3 types. The type 1 is estrogen related. And I think that this is the most important one because it is related to obesity. It actually has a very common histology of the endometrial, and it's usually low grade. So I think that this is something that we are very focused on, especially with obesity. And I thought this was really interesting because about 13 cancers can be related to weight. In fact, cancer of the endometrium is one that's the most associated with weight. So I think that it's a good conversation for us to start, and we don't want cancer to win. So what about the role of obesity and endometrial cancer? In actual fact, 40 to 60% of endometrial cancer is attributed to obesity. So it means that actually it's a preventable cancer. So for every 5 BMI unit that is increased, there's a 50% increase in the development of cancer. So this is a big deal, I think. And what is also really interesting is that women, if they are overweight in the early adulthood, in the 20s and 30s, and this weight has been maintained, so their overweightness is maintained throughout their life, they have a greater risk of developing endometrial cancer than if you become overweight in later life. So what does that mean for us? That means that in the next 20 years, in the next 10 years, in fact, there will be a 55% increase over what we had 10 years ago. So it is a major problem, and it's a major problem in a lot of developed countries. Now, this is a bit that Carol will probably know best. I'm no scientist, and so I've just distilled it into a very simple diagram. In fact, obesity is driven, obviously, by estrogen. And what happens in adipose tissue is the androgens are changed to estrogen. We've got increased insulin because of decreased sex hormone binding globulins. And so you get more free estrogen, and then you get the adipokines, which basically cause inflammatory sort of environment. And in that particular type of environment, it's likely that the healthy endometrium can become complex hyperplasia and endometrial adenocarcinoma. But on the other hand, there's other options like diet, exercise, hormone therapy, and chemo prevention. So this is my only scientific slide, as I say, simple surgeon, simple slides. So this is just to give you an idea about the patients that, we had a snapshot of this 2 years ago when I was in Auckland. We decided we just take a snapshot of 6 months and see what our patients were like. And I looked at this and I thought, oh, yeah, that's all fine, they're fine. But in actual fact, if you actually look at the weight categories and look at the BMI, actually 55% of our patients are obese. And I didn't even click. I just thought that, oh, it's fine. Of course it's not fine. But because my brain is set to the fact that BMI 40 that we do every week or more, it's acceptable and common. And in actual fact, it is not the right thing. And 23.5% of our women will morbidly obese. So I don't know what the figures are now. This was 2 years ago, but certainly I don't think it's going to be any better. But this is just a reminder for reality check. I'd like to just briefly talk about metabolic syndrome and endometrial cancer. And those of you who are smart and will know that what this is about, and obviously I have to remember metabolic syndrome is obviously hypertensive, obesity, high triglycerides, and also diabetes. And what is really interesting is obviously as you get older, the prevalence increases. But what we find is that when the prevalence of metabolic syndrome increases, endometrial cancer also increases. But what is quite positive is that if you can target and mitigate one of the risks, you can actually decrease your risk of endometrial cancer. So I think this is important. And this is just a slide to show you that in actual fact, BMI and cancer, that the strength of evidence in humans is quite strong and is probably the strongest in endometrial cancer. So what do the public know? What do your patients, what do the public know? Not really a lot, actually. In the general population, and this study was done in the States, and it says that really 58% of women did not realize that obesity and endometrial cancer had any association. Everybody talks about cardiovascular and strokes and things. And women did not realize that, that there was this association. And even when they got the cancer, 35.9% didn't know that there was any association. But once they knew, they were very interested in weight loss. So we know that there's a lack of knowledge, lack of public knowledge, but it's also an opportunity for intervention. So what are the key drivers that we can use to prevent obesity-driven endometrial cancer? Obviously, diet and weight loss, and it is easier said than done. And you need to really lose about 9 to 10 kilograms to decrease the risk. Exercise, they say you need 20 minutes of moderate intensity to increase your heart rate probably to 5 times a week. Bariatric surgery, and this is definitely decreases your risk of endometrial cancer. We know that, and we'll talk a bit about that. And certainly, obviously, Mirena is helpful because it does decrease the risk of endometrial cancer in this high-risk women. Now, I think that it's very easy to say diet. It is a very hard thing to do, and especially if you enjoy food. And obviously my favorite exercise is chewing, and I think that there's nothing wrong with it. But obviously we just have to be really careful about the weight. What about bariatric surgery? This is really important, I think, because it does lead to dramatic sustainable weight loss. And in some people, once they get to a certain level, it is really hard to actually lose weight. But we do know it works because there's a 60% reduction in developing endometrial cancer in this particular trial they did in the UK, where they looked at control versus an arm that actually had bariatric surgery. And certainly for younger women with complex atypical hyperplasia, very early stage endometrial cancer, the referral is well received, and that we know that there is an advantage. And I think that is a cost-effective ratio, and it's quite cost-effective. So it is something that we need to think about, and I think that is something that I know some of the bariatric surgeons in Auckland are keen to pursue in some patients. I think it's really important that we step back and reflect on what are the clinical features. Everybody knows about this, but I just quite like very briefly to say that abnormal bleeding in women, and certainly postmenopausal women. And I think that now there's increasing number of premenopausal women with high risk. So I think that any abnormal irregular bleeding we need to think about, especially women who are in higher risk. So I think that any abnormal bleeding we need to take notice, especially in the high risk women. So in terms of diagnosing endometrial cancer, we know that there's a 40% increase in the younger women, and it's my concern, and I'll share with you some of the data that we have a bit later. So in Auckland, less than 45-year-old makes up 15% of our patients. And so I think that we talked about that before. Irregular heavy bleeding, certainly if there's other risk factors, is something we need to think about. Though endometrial biopsy can be challenging in this woman. So this is our group of that we looked at, and it's a group of less than 45-year-olds, and certainly in terms of ethnic representation, the Pacific Island population are very overrepresented, 49%, and Pacific Island population, New Zealand 7%, the Maori 20%, and obviously 15% in the population. That we need awareness in younger, and a lot of these women are morbidly obese at diagnosis, but a majority of them are low grade and low stage. And also, concurrent ovarian disease is low. So the aim in this sort of woman is that we need to preserve ovaries. And fertility preservation is an important thing to discuss, but obviously we need a clear pathway, and I don't think we've got that at the moment. So when someone has endometrial cancer, what are the treatment options? Obviously surgery, hysterectomy, bilateral self-injectomies, plus or minus ovaries, depending on age. Nodal assessment, at times we would need to do that, and I'll go to that very briefly. Node dissection or central lymph node, and I realize in the Pacific we are limited by some of the treatment options. Radiation, primary or adjuvant treatment after surgery, sometimes chemotherapy, and sometimes conservative treatment. So I think that I'm just now going to talk a bit more about when we go into surgery, and I'm assuming that the audience is from the Pacific doing some of the work. So I think it's really important that we actually go through some of the steps. So in terms of any operation, I think that we need to talk about pre-op preparation, what you do during the surgery, what are your post-op cares for the woman, and what resources do you have available, and ergonomics. So in terms of pre-op, I think that it's really important to work out the comorbidities. Obesity is usually associated with other comorbidities. I mean, certainly for us in Auckland, usually they would need a high dependency unit. We need to plan our list because it's not something that is to be taken lightly, and we need to allocate the right time, the right equipment, and the team for it. So anesthetics, we always sit around and go, come on guys, get on faster, but they do have their own challenges. So things like access, vascular access, regional is difficult, intubation is difficult, ventilation for them is difficult, and obviously we are wanting head down, they're trying to maintain the airways, And so I think that you really realistically for this really obese woman, you probably need to allow about 2 hours and to have a facility for the woman to be looked after afterwards if you embark on this. In terms of instruments, I think that it's really important that you have the your right energy devices, your bariatric instruments. As you can see, the length of them different. Having a good light source is really important. Retraction. This is what we used to use in Auckland, and it's a grace retractor, and of course it takes away, multiple people have to put their hands in. So I think the good retraction, if you can get it, I'm not sure whether that's available in the Pacific, but this is very, obviously we would have all that, and this is just to give you an indication of the length of the instruments that we would use in open surgery. And some surgical tips, we would normally go in the midline, but we would go actually just under, just above the belly button and just down underneath. And where the finger is pointing in the distal port, we always remember where the penis is. Actually, the actual pubes are different. So you need to feel the pubes. So never, ever go into the penis. Just actually go a bit before that, as you've seen in the picture. Always make sure you got good access and go right down to the sheath. So basically what we do is we cut through the fascia. We actually, if you lift the fat and tear the midline, it will show you where to go. And the omentum, if we can manage that, do that first. Avoid the penis at all costs. Stand on boxes if you need to. Certainly I need to, sometimes multiple boxes, but this is a one that was made for me in Auckland. Use gravity, change sides, basically have a friend, have another surgeon who can do the work. When you have the opportunity, do what you need to do and get out, because your opportunity will get less and less as the surgery goes by. So what other things that we use? We sometimes use things like, obviously, antibiotics. We use a drain in the subcutaneous fat because that's been shown to help with decreasing infection, seroma. We use deep tension sutures, and this is a pickle dressing, which I know is about $750 per dressing, but it does decrease risk of infection and seromas. So what about post-op? We actually do use a ERAS, which is enhanced recovery, get people moving, get people mobile, drinking and eating quite quickly, get the catheter out, and obviously the Clexane for 28 days. So I guess what I think I'm missing a couple of slides here, but I'll carry on. What is the effects of obesity and surgical management? Obviously, obesity actually does complicate clinical management. Obviously, we talked about technical of the surgery. We've talked about medical comorbidities that impact on care during and after. Obviously, surgical complications are highest in obese women with open procedure. And so we would actually prefer to use minimally invasive approach if we can. Sometimes people are still not operable. And if that's the case, radiotherapy is an option. And I'm just talking a bit about sentinel node. This is just to give you interest. I know that you are unlikely to be able to do that. Sentinel lymph node is actually the first lymph node that the cancer, it comes from the primary tumor. So what we do with the sentinel node is that if this is positive, we know that we need to treat. So we don't take the rest of the nodes out. If this is negative, then we know we don't need to do all the lymph node dissection. And in fact, it's better in terms of detecting a positive lymph node than a full node dissection. So this is what I like. And I like to do, this is a not very good picture that I've got of what I do. I do this laparoscopically. Obviously, I have the privilege of being able to do that. And so we inject in ICG into the cervix, and then that lights up. And then we actually look for the node. And it's an alternative. It's got less morbidity for the woman, and it still provides full staging for the woman. I'm then going to go from surgery to talking a bit more about radiation. And so radiation we sometimes use, I know that we don't have that in the Southwest Pacific, but we use that to prevent recurrence. It actually usually is used as a brachytherapy, and that's just the picture next to you is just what they use to put insert into the vagina. And that is just mainly for brachytherapy. If women are really unfit, then obviously they need full pelvic radiation. We know that it's inferior to surgery, but you obviously got to do no harm. So you can't have your patient not survive. So they would, at that stage for a primary treatment, use external beam and then use intracavitary, which is the brachy But the brekkie sometimes needs in terms of if you've taken the uterus out, they don't need GA, but if you don't, then there is a system that shows you as a primary brekkie, they will need GA. So basically, they need to insert these instruments into the uterus, and then they have so that's done in theater, and then they will go down and have the imaging to make sure everything is in place, and then we will load it with the radiation source. So this is brachytherapy after the external beam. So I'd like to just share a few slides on conservative management, because obviously it is something that we're seeing a lot in younger women. So we need to think slightly differently. And obviously the indications are if women have atypical hyperplasia, certainly low-grade endometrial cancer, unfit for surgery, or because they want to have fertility. And traditionally we've been using MPA, and but now obviously Mirena is available as an option. The initial success rate is quite good, it's 50 to 65%, but the recurrence rate is about 25%. Mirena certainly has less systemic effect. So it gives women an opportunity, a window of opportunity, I think. Usually what we would need to do is to make sure that we just have an early disease or hyperplasia. We would need to review the pathology to make sure that that's what it is and nothing else. And usually biopsy sort of 4 monthly for year 1 and twice year 2. And some people have recommended hysterectomy after childbearing because of the recurrence rate. And I guess that really depends on how the woman's doing and what weight loss she's achieved. And that is a personal, I think, a case-by-case decision point. I think that to me, we usually need to use the 6 to 12 month window to address what the cancer is. And I think that, we always say at MGT, well, conservative treatment useless, but I believe very strongly that we actually do need to, if we're going to do this, we're going to say, how are we going to help you lose weight? How are we going to reduce your recurrence? And how can we do this in a fashion together with the fertility experts? Because if that's what we're going to do, and I know they don't want to see them because they're overweight, but a conversation, and they're usually pretty good with our patients. But I think that if we're going to be conservative to discuss fertility, then we need to do something as a package. We can't just go and say conservative, come back in 6 months. No one's going to lose weight. No one's going to go do anything. And in the end, they all end up having a hysterectomy. So this is just to show you that actually conservative management works. So this is this woman with an arrow showing her endometrial cancer. And obviously she is considerably bigger than when she had lost weight and the regression of the tumor. So I think that we know that it works. And I'm just going to talk a bit about this premenopausal woman, and certainly I know I'm sort of harping on a bit on it, but I'm really very concerned about this because this is something we're seeing a lot more of. And certainly we know that in early stage disease, ovarian conservation is really important, and there's no impact on, in terms of their survival or their all-cause mortality. So it's really important to save the ovaries we can. And in terms of fertility sparing, we've talked about that before. We know that there's initial regression, but there will be relapse. But there's been some success, and 28% had at least one live birth. And even so, there is a great need for them with assisted reproduction because a lot of them would have PCO and have those issues. But it's something that I think we need to consider. Certainly in New Zealand, I know it's a bit hard to manage this in the Pacific. I guess one of the things that people always ask is that, does obesity make the cancer? Do you have a worse outcome? And I think that the reason that it does that is because they don't receive the right treatment. They don't receive optimal treatment, sometimes because you can't. And when women receive standardized treatment, there's no difference in terms of the cancer-specific survival. But what obesity has is a negative impact on all the different mortality. And 67% of cases after deaths after that were actually non-cancerous. And I remember this quite clearly. And it's a very sad case that many years ago, I was involved in helping someone do a case from Tahiti. She was only in her late 30s. She was grossly overweight. And so they decided to do the surgery vaginally. Unfortunately, she then had a major bleed. We then had to do a laparotomy, and I remember standing about multiple stools doing this. And we were very pleased to be able to get this woman home, and she was well. And unfortunately, about 9 months later, we had news that she actually died while walking on the beach from a heart attack. So I think that for me, sometimes it's really important to have a personal history and a personal story to tell, because it's actually about the woman. So I like to use endometrial cancer as a sentinel event. We know that obesity kills, and we know that this is something that we can use to prevent all these other things. So what are my take-home messages? Because I've actually missed a few slides, Cara. I'm not sure why, but maybe I can look at that and go back a bit into if we have time. So I like to just, in New Zealand, increasing number of women, Pacific Island and Maori. We need to be aware of diagnosis in premenopausal women. I think that there's a role of conservative management, but we need to have a multidisciplinary team. And I think that we can use this to decrease future mortality from cardiovascular events. And what I might do next, guys, and so I think it's about teamwork, but if you could bear with me, and I'm not sure why we've got this problem, I just want to go back into some of my slides, which I've missed for some reason. And, and I think that this is the slide that I've missed, actually. I don't know why we did. And this is just, so I'm just gonna show you this. This is endometrial cancer in New Zealand, and this is going up. And what I like to say is that we are the second or third in terms of our obesity rate. And we've talked about the ethnicity, and we've talked about this. Sorry, I'm not sure. Some of my slides are missing, so bear with me for a minute, because I'm just going to end show and just have a quick look at what's missing, and then perhaps we can have a conversation about questions. But I'm missing some of the slides. I think that just bear with me, everyone. I think the one that I wanted to share, and I know that this might be, and I don't know why it's missing, but this is what we sometimes use, and I think that it's something for people to think about. There's a case for low-calorie diets, certainly before pre-op, before surgery, and it certainly gives you rapid weight loss, and it's a reduction of liver volume and adipose tissue. And I think that for the 2 or 3 months in endometrial cancer, it's not a fast-growing cancer. You do have time to do that. And it improves insulin sensitivity, fasting blood sugars, decreases your blood pressure. And they use it in a form of other surgery. And the compliance is very good. And it's about $2 to $3 per meal replacement. And suddenly in New Zealand, that's how much it costs. And I quite like to share a story with you about this. I had a woman from Tonga who was sent here, and I've seen one of the colleagues, and they've decided that I needed to do the surgery. And I had said to her, I don't think it was possible in the setting in private, because I didn't think I had enough of some of the backup for that. So we talked about it, and she was not the resident. And in actual fact, what we then did was we talked about this. And she said, well, actually, I am really motivated. So with her and her cousin as a buddy, they went and did this for about 10 weeks. And she lost about 10, 15 kilos. And they were really strict. They were amazing. And so actually we did the surgery for her. She did really well. And so I do think that if, sometimes I'm just looking at different options and things of what you can think about. And sometimes it's good to think outside the square and say, well, what else can I do? And what can I do in terms of helping this woman and doing things so that we can actually assist them in terms of their journey. So that's what I'm going to talk about. And hopefully that's all right, because if you've got any questions, I don't really, my attention span is usually about 20 minutes plus. So I'm assuming everybody is the same. So that's hence the length of the presentation.
Thank you, Ai Ling. There is a question that's come through on the Q&A. Thanks, Doctor, for your presentation. How we screen for endometrial cancer and what are important symptoms, bleeding, post-menopause, or sonography scan?
Well, I'm going to say there's no screening for endometrial cancer. So we don't go out and scan everybody. I think that what we are looking for is a high awareness that when people present with abnormal bleeding, and if they have the high risk group, and in the high risk group, then we should investigate. And I think that that will be, and yes, obviously, investigation, ultrasound, and an endometrial biopsy. That's what I would do. I hope that answers your question.
Yeah, I hope so too. Yeah, it's a real issue in New Zealand, and you're right. You know, with the rates of endometrial cancer going up and up and up. If you were, you know, this is for us clinicians. So what our concern has been that we, you know, as clinicians, we catch the women at the bottom of the cliff. Right. So all our treatment is about treating them when they've already got endometrial cancer. What would your advice be for those sort of heading that way?
Well, I personally think that it is something that we should actually prevent. And I think that we know that if an obesity, and I think that the government is talking about that. And I do think that if we can actually go to the community, I think that we can increase awareness for women that this can happen. And so that's one thing. So the prevention, I think, in terms of the where there's diet, exercise, and we do also know that women can't do it alone. I think there should be some package or something, some program for them. We can't just go and say lose weight, because I believe that after a certain level, it's really hard to do that. And women have multiple sort of responsibilities, and they always last on the list. So I think that we need to perhaps even start from young, start from the school children, start at school, increase awareness in that, in a community, have access for women to be able to go somewhere safe where they feel comfortable, that they can have someone help them do that. So I think for me, certainly education and a community process, sort of community type sort of importance, rather than doing what I do, because what I do obviously is just treating cancer. But I like to think that we actually increase the awareness in the community, and that happens from the grassroots. And that's why I think that in engaging with culturally appropriate elders in different communities, and what I would like to say from my perspective. So let's say, I know you were asking that question, but I just want to stress on something else, which is that when someone's diagnosed and I've treated them, I have a very kind conversation with them, but I actually say to them, do you know that this has contributed to your cancer? And do you know that if you don't do anything about this, that's going to kill you in 5 to 10 years for cardiovascular disease? And that's been well proven internationally. So we talk about that, and most women agree. Most women are happy to actually talk about that sort of weight loss and be positive. But what we don't have, I feel, and I could be wrong, but it's certainly not within where I've worked, is how do we go, do that package for that woman to go, okay, you want to lose weight, here's this program for your diet, we help you with your nutrition, we help you with the exercise, we help motivate you to actually prevent you, because they're younger women. So therefore, I think that that's really important if we can do both ends. But that's just my personal opinion. So what are your thoughts, Cara? Because you've obviously done a lot of work in this area.
This is huge, and I think it's one of the things that, yes, it's a huge concern. At the moment, we're trying to work out how to best address this. I mean, when they get to your level, they're already, they've fallen off the cliff. What we're not doing very well at the moment is, just like with cervical cancer and with breast cancer, endometrial cancer or cancer of the lining of the womb have to be a priority up there. And unfortunately, it hasn't really reached that stage yet. But I think small steps now in this, in us raising awareness. And it was one of the key things I think would be also our scientists to also come on board around the research and around how do we do this well. Like you said, when they already have endometrial cancer, we're already in the battle, in the heat of it. We don't have to go into that battle if we can avoid it. But it's something I think in the future we'll have to start thinking about, bariatric surgery, say, for example. We've got some scientists who are working, some general surgeons, and they've looked at it, and there's a lot of evidence around that when women lose weight, you do actually reverse not just the diabetes, the obesity, the diabetes, the cardiovascular disease risks, but also endometrial cancer, cancer of the lining of the womb. And there's a lot of issues now around women, young women who are now got early endometrial cancer. We're trying to reverse it so that they can be able to have children. But there's quite a few questions that have come through, Ai Ling, and one of the is from
I saw Pushpa. I've seen one from Pushpa.
Yeah, so there's questions, but there are also people on the chat. So one of the owner was asking, do you think the requirements for Countess Manukau GPs to have a Bepal biopsy result before referring any patient with abnormal uterine bleeding is a barrier for women? It's hard for GPs to access training for this, so there aren't many GPs who do it, meaning even to get a diagnosis, a woman come in with heavy menstrual bleeding, you're suspicious that she might have cancer of the lining of the womb, but she can't access or have a test because Countess Manukau now is not seeing them. They have to be done by a GP before they get referred. So that was one of the questions.
I don't work in Countess Manukau, so I'm not quite sure what your referral system is. Do they have to?
So now they're not going to be accepted, but I think that's something different that we probably will have to deal with. It's slightly different from, so Countess is not accepting anybody to be seen unless they've had a Bepal and an ultrasound scan result.
So how do the poor GPs do that? I mean, if they've got a high risk women who are grossly obese, how are they going to expect the GPs to be able to manage that in their rooms? I think that's totally. Are they not actually? Is there no way of actually saying that? Okay, generally fine, but you have this high risk group, and we know that this high risk group exists. We know that they're a lot younger, and can they not perhaps do something about that? I mean, as I said, I don't know because I don't work in counties, but I would have thought that would be rather than a blanket.
Yeah.
So I think the owner's point is very relevant. I think that it's hard to do a Bepal. Doing a Bepal on someone who's grossly obese is really difficult, and the GPs do not have the facilities to do that. And I think it's really unfair on primary health. Sorry, I'm not having a go at Countess Manukau at you, Carol. I just didn't know. So I think that was very relevant, and I think that that's inappropriate. But then that's my personal opinion.
Yeah. And as you know, that there's a very high rates in our region as well. It's something I think we probably may be outside of this, but we're going to have those conversations continue on. Now, there's another question here.
Okay, I had a question. Which one are we going to do first, the chat or the Q&A?
We can do the.
We can do the Q&A.
You can do the Q&A because you're looking at it.
Yeah. All right. So Pushpa would like to know which sentinel node would you remove? Well, Pushpa, the idea with the sentinel node is that what we do is we inject the cervix with isocyanate green, and what that does is that it takes, so the sentinel is the first node that the tumor goes to. So what we then do is that I usually do it laparoscopically, and what happens is that we have a special IR tower, and we switch it to that particular IR infrared sort of spectrum, and we will pick up there's certain pathways that it goes to, and certainly it usually goes across, sorry about this surgical, but she did ask the question, sort of it does go across the obturator sort of obliterated umbilical vessels to the external iliac chain. So that's the most common one. Sometimes it goes along the internal iliacs up to presacral and para-aortic. So you usually can see the channel, you usually then see the node, but it's not something that you can just do. You do have a learning curve, and you need to actually open up your pelvic side wall still and look for those channels and look for the nodes. And once you know that, you then obviously you have to be gentle or not, because if you're not gentle, what happens is the dye will go everywhere, and then you just look for the green note, and then you take that. If we have a case where we would do it for high risk because of high risk histology or for other reasons that need staging, and we don't find a note, then we actually do a whole note dissection. So hopefully, Pushpa, that answers your question.
Yeah. Okay.
Regards,
there's one
no
leading on
radiation.
to that.
The radiation one, like usually we do radiation, but if there's no radiation, that it really depends on what else you have, whether you've got a bit of chemo. Does chemo, we know that chemo works if there's stage 3C. So chemotherapy it's for us, we use it for specific reasons, but I'm not sure what the role of that in a stage with when there's no evidence of when there's no radiation. I think it just says 1B to 2B disease, really, that's the only thing you've got. And so that's the only thing you've got to use, I guess, if that's the case. Have I done all the anonymous? That's the anonymous one. Have I done that?
Yeah,
okay.
You've done that. And
all right.
there's some on the chat.
Okay, so I'm going to go into
David
the chat.
Schaff was asking.
No, there's one before that.
Oh, yeah. So there's one. Is IVF possible after endometrial cancer treatment? How long should we wait for IVF?
Okay, I think that I think that there's no, for me, from an oncology point of view, if the cancer has regressed and you know that the cancer has regressed because you've done the biopsy and there's no cancer, then that would be the time that I would recommend that you talk to the fertility specialist in terms of the IVF at that stage, because as we know, there's a risk of recurrence. So I hope that answered that question. So it's really about making sure your tumor is not there anymore, and then treating. And that's why, for me, I think that if you want to do this fertility thing and conservative thing properly, you really got to have the whole team that are in the party. And I know that, so my ideal situation is you get a young woman, we've diagnosed it's early or complex atypical hyperplasia, you talk to the bariatric surgeons, and I have done that. I've done this. But, obviously as an ad hoc, they take the woman in because she's done all the right things and she's motivated. She loses her weight. She then loses enough for her to try to get pregnant. If she doesn't, then the IVF people or whatever, how they stimulate, whatever they do to get her pregnant. So that would be your best scenario, but we don't have that at the moment. So that's why I'm saying, if you want to say an advocate, you've got conservative management, you got to do it properly for people. You can't just say, all right, go away for 6 months and come back and we'll see. Nothing's going to change. I've seen that long enough. So hopefully that answers that question. So David Chef, let me I think public health, opportunity public health, absolutely. Not public health at schools and also in the communities. I think we need to target every stage, is how I feel. But I don't really know how we do that. And I think the next one is Nani, who I think I've answered. We really don't have a choice. When you don't have radiation, you can try some chemo. That's about all you've got. And so honors we've done. Leanne's. I don't think that Leanne, about the sentinel nodes, because you really need to actually do that. You actually need your equipment. So you need the dye, is hard to get by, and you also need your equipment and ideally minimal invasive. So my first response to that would be, if you can do the hysterectomy, that would be a first step. And I think that we've got to be pragmatic in some of those women. If you can't do the hysterectomy, that would help them. So, and then you can then, they obviously, assess it differently, after that. But I think that it's going to be quite challenging to actually even think about sentinel node biopsies in the Pacific at this moment in time. So if Leanne is still there, maybe I'll give us what your opinion is on that, because I think it's just a bit unrealistic at this moment, because we're just that is very challenging. I think that the basics first, and if we can do good sort of basic surgery with the equipment for your basic stuff before you even do the sentinel node. Are we good?
Ai Ling,
Have I
can I ask?
done everything?
Yeah, it's interesting. Just going back to David Schaaf's one about
Yes.
that they found that Pacific adolescents have menarche earlier compared to other ethnic groups. Is that a risk factor for developing endometrial cancer?
I don't know. I mean, you know, is it the obesity? Is it, you know, why? I mean, is it just, would you have endometrial cancer if you developed normally and didn't have obesity? I mean, what are the sort of other populations in terms of who have early menarche? Do they have an increased risk of endometrial cancer? No, not quite sure. Don't know. But I mean,
Sorry, carry on.
No, I was just saying that I am not quite sure about that. But and at the moment, we have a lot of opportunities to actually do something, you know, currently. I mean, yes, that's another interesting factor, but we've got a lot of things that we know that we haven't been able to manage, you know. So I think that interesting, but I don't know what it is with other, you know, when they grow up, are they obese? If they're obese, I mean, so we don't know. I mean, I can't answer that question, Cara. You might be able to, you know, just doing the research.
Yeah, we I haven't actually. That's a really interesting question because I haven't thought about that, to be really honest, about early menarche. There's also a question here. What's your limit in terms of BMI for total TLH and sentinel nodes? Just thinking of post-op recovery. Oh, I think you've gone on mute, Ai Ling.
Okay, first thing I'm going to say, Nani, is that you got to do the basics. So I think that open surgery, do it well, laparoscopic hysterectomy, and if you have to do laparoscopic surgery and node dissection, do that first. You know, the ICG is going to be basically a bonus. In terms of the BMI, it really depends on what your hospital is going to be able to manage. It's actually not just the BMI, it's actually the anesthetist and how they actually guess the patient, what they use and what they're prepared for, and how competent you are as a surgeon and your team in terms of, like, a lot of times we would go, okay, go down. We'll go for a couple of minutes, and when we're better, we'll let you come up a bit. So we tilt up, down to manage it sometimes, but you need to have a team that's committed. And so I don't think per se BMI alone. I think that people have done BMI. I personally haven't done 60, but I know people have done that laparoscopically. But I think it's actually your team. If your team is set up and your theater is set up and your HDU is set up, that's what is really important. That's what I feel. Hopefully that answers that question. And then there's a question about follow-up with Mirena use in endometrial cancer patients. Well, here we always sample them every 6 months, look for regression. If they're regressed and then they want to try and get pregnant, we give them the opportunity to do that then. But obviously, if they don't regress within a period of 9 months to a year, then you're unlikely to get that regression in that particular patient. So Topo, I hope that answers your question.
So does that mean that if it doesn't regress after 9 months, 9 months to 12 months, what's the management after that?
Well, I think you've got to offer them, you know, you've got to say that, you know, you haven't responded. I mean, yes, during that time. So you might go 6 months, not regress, and then you go, okay, I've got the Mirena, but I'm going to really push this with, you know, some people would use oral progesterone on the Mirena. Is there a lot of data on that? I'm not sure there is. Right, but that makes you feel better that you're doing everything you can. But they're also at high risk in terms of their obese, so you don't really want to be giving them megas like crazy. When you know, so I'm interested to see what the data. There's some data, but not a lot that says that adding more progesterone. But if they're not going to respond within the period of 9 months, they're not going to respond. Especially if you've got the Mirena. In the old days, that's different, because I remember very clearly having a 19-year-old who we treated conservatively, who we gave Provera, who never responded. And you know the reason it never responded is because she never took those tablets. And she admitted to that after. So she ended up having a hysterectomy in her early 20s because it just got worse and bigger and nothing. And then when I saw her down the track when she was in her late 20s and she was a charming, lovely adult with a job, she goes, you know what I used to do? I never used to take those tablets. And I said, well, I suspected as much. And she never came to clinic, but she come to the hospital and you see her. So it's just like, so you got to manage the person. And I don't think we have done that well. We don't have those resources to actually engage the people. So I think it is a hard one, the conservative management. It then needs a lot of resources and effort and the trust, and the women do come and say that they wish they'd done it differently. But, you're 19. What do you do when you're 19? You do everything you're not supposed to, of course. You don't expect to get endometrial cancer.
Yeah. Because we know that there is a link with high BMI and endometrial cancer. What would you like to see in the public health arena? Well, especially, in the Pacific, a lot of our colleagues know this. The rates, the BMIs, and now young women is going up and up and up. So what's happening here in New Zealand is going to be mirrored and it's going to happen in the Pacific as well.
Well, I think that for our colleagues in the Pacific, in the public health arena, I think it's a time to start working now. Don't do what we've done, which is just to wait until it goes up and it's carrying going up. And it's a time for them to actually maybe reflect and think about why is that happening now and try and get in early rather than doing what we're doing now, which is, a very steep curve. So I think it's those messages about awareness of endometrial cancer women, and I think that's really important for women because it's younger women and it takes away their fertility options. And whether you want to have a child or not, it's nobody's business but your own. But to be given that to not have the option, I think that's a sad thing, and I don't think women know that. And of course, it's their health and the fact that it's associated with other health conditions. So I think that maybe if that's happening, and as I said, I don't know that in the Pacific, but if you think that it's happening and that's certainly happening, it's an opportunity to be more proactive than reactive.
Yeah, I think that's what's going to be happening in New Zealand. We're going to be reacting.
Yeah, we are reacting.
It's here now, and we are going to be very overwhelmed. There's a question by Ashnil Singh. Hi, what would your cut-off age would be for performing a bilateral salping oophorectomy with the TAH for endometrial cancer ladies if we are not into fertility preservation? Thinking of the possibility of future ovarian cancer if BSO not done versus subjecting to the surgical induced menopause if they are in their early 40s.
Okay. Well, my answer to that is the same. And I would say that I don't think there's a specific cutoff. I think that, I would certainly try and preserve the ovaries, but, ovarian cancer, the incidence is low unless a woman has a family history, and that we can take the tubes out. You leave the ovaries and take the tubes. And I think I've said that in my slide that we do take bilateral salpingectomies because we know that decreases ovarian cancer by 30%. So I do think that we can preserve the ovaries because I think that menopause is not fun. And there has implications in terms of cardiovascular, cognition, and bones. So I do think that that's definitely something that that I would still do, and I would have a conversation with the woman. And I think that I would definitely take the tubes out because obviously ovarian cancer, we know that it's 70 to 80% is from the fibral end of the fallopian tube. So that's what I would do. I hope that answers your question, Ashnil.
Yeah, I think that's quite a good answer, Ai Ling. It's one more from Pushpa. Whether you'll be happy to share your email with Pushpa. She's saying that they are seeing younger women with endometrial cancer, and discussions would be really good for patients, like for them to have some guidance of how they could be guided around discussions around management of endometrial cancer. So that's what basically Pushpa was asking.
Absolutely. Pushpa has got my email on my phone so many times, and I had no idea. He obviously said, oh, Ai Ling, throw it away again. Absolutely, that's no problem.
Yeah. So Pushpa, be assured that I'm sure Robert is listening and he can send you Ai Ling's email to you. It's your Gmail one, isn't it, Ai Ling?
Yeah, the Dr. Tan one. That's fine.
Yeah, the Gmail one. Yeah, well, I think we are 7:59. I know we started a little bit late because we had just a couple of technical, it's strike 8 o'clock now. But, thank you very much for you, Dr. Ai Ling Tan, for joining us this evening. Thank you for everybody who's been joining in. Just to let people know, this is actually mostly for clinicians in the Pacific that we do a lot of this education for them, and we do these webinars. But because we've been putting it on Facebook, I think there's been some interest from the public. In the future, maybe we could have one that's tailored for the public, seeing that I think some of the public have been asking. And then the COVID hit. Today, we're going to be on level 4 tonight. Great in the Pacific. Yay, great for some of you countries in the Pacific who have got COVID. You should be rejoicing, be very glad. I hope that our colleagues in Fiji, I know it's still a struggle for you there, but we're still remembering you. And and for those whom I didn't really introduce myself, I'm Clara Oxeningafa, obstetrician gynecologist here in Auckland, based at Middlemore Hospital, also University of Auckland. So I'm really sorry I didn't introduce myself earlier, because I just assume most of you do know me. And Dr. Ai Ling Tan, thank you so much for your time. Roveti, are you going to come on and close us and with our audience? Yeah, back to you. Thank you, everybody. And for Roveti to close us now. Thank you so much.
Thanks, everyone. I'm sorry about my slide thing. It malfunctioned, so I'm not sure why. So apologize for that, everyone.
All right.
Okay, thank you, Dr. Ai Ling. Thank you, Cara. Thank you, all participants. Let's close with a word of prayer. Father, we want to thank you and bless you and honor you. Thank you so much for this opportunity and privilege, Lord God. Thank you for having Dr. Ai Ling. Thank you for sharing her knowledge, her experience, Lord God, with all the participants, Lord God, here in the Pacific. Father, we continue to pray, Lord God, for Lord God, for your blessing, being healthy mom, healthy babies, healthy young women, Lord God. Lord, pray, Lord God, that we continue to step up, Lord God, in the prevention side, Lord God, that all our women, all our girls, Lord God, will know this knowledge, will be promoted to the community, oh God, to the schools, so that they will be aware of this and be able to do something about it. Lord, we continue to ask and for your blessing, ask for your healing, for healthy mom, healthy babies. In the name of Jesus, we pray. Amen.
Amen. Thank you. So just to let you know that this will be, this webinar has been recorded and we'll put it on our Facebook page as well for those who might want to, who didn't have the opportunity to look at it. Yeah. Thank you very much, everybody. Ka kite. Kia
Thank you,
ora.
Ai Ling.
Thank you.
Thank you, Cara.
Thank you. Thanks, everybody.
Thank you, participants.
Thanks, everyone.
Thanks,
Thank you for
everyone.
joining in.